Hello and a warm welcome to this latest Science Custom podcast, created in partnership with Bold, the blog on learning and development. I'm Sean Sanders, Director and Senior Editor for Custom Publishing at Science, and I'm pleased to invite you to join me for this series of podcast interviews with outstanding researchers who are attempting to make positive changes in the lives of children and adolescents by seeking practical solutions for a complex world. Apart from this common goal, they are also all recipients of the prestigious Klaus J. Jacobs Research Prize, a 1 million Swiss francs grant awarded by the Jacobs Foundation that recognizes exceptional achievements in the field of child and youth development. Today, I have two guests with me, a husband and wife research team, Dr. Terrie Moffitt and Dr. Avshalom Caspi. Terrie is Professor of Psychology at Duke University and Professor of Social Development at King's College London. She studies the consequences of a lifetime of mental and behavioral disorder on processes of aging. Avshalom is Professor of Psychology and Neuroscience at Duke University and Professor of Personality Development at the Institute of Psychiatry, Psychology and Neuroscience at King's College London. His research spans the fields of psychology, epidemiology, and genetics, and is concerned with how childhood experiences shape aging, how genetic differences between people shape the way they respond to their environments, and the best ways to assess and measure personality differences between people. Terrie, Avshalom, thank you so much for being on the line with me today.
Thank you, Sean.
Pleasure to be here with you.
You both study such a broad range of topics, so I've had to narrow down our conversation somewhat today to just a couple of areas that I thought would be of greatest interest to our audience, those of aging and mental health. So Terrie, why don't we start with you? One of the takeaways of your research, as I understand it, is that we should not just be studying the elderly when we want to understand aging, but rather we need to look earlier in life. What can studying the young, particularly children and adolescents, teach us about aging?
This is a really great question because usually when I tell people that I'm studying aging these days, they get a bit of whiplash because they think, oh, goodness, I thought that you were a child development researcher. So this gives me the opportunity to tell you what we've been doing in the past 10 years or so since we won the prize from the Klaus Jacobs Foundation, and in fact, what we've been doing with the prize money. So Avshalom and I have joined a newly emerging field, which is called geroscience. And the aim of this field is to find ways to slow down aging. Now, that might sound like science fiction, but the reason that geroscientists want to slow down aging is that biological aging itself is a cause of all the major diseases that rob people of their vitality and happiness at the end of their lives in those last maybe 20 years of life. Heart disease, lung disease, kidney disease, joint disease, liver disease, brain disease, cancers. All of these increase exponentially as people grow older. And this is because as we age, the body's cellular repair mechanisms wear out, and this makes us vulnerable to getting these kinds of age-related diseases. So geroscientists think if there's a way to slow down aging itself, then the onset of these diseases could be delayed and pushed later. Now, the agenda in this field of geroscience is to lengthen not just the lifespan, so not to give people extra years of life, but what we want to do is try to lengthen the health span. So this is the number of years that you live without getting any disease. So what could we do to slow down aging that could be studied by people like me and Avshalom? We're psychologists, so we don't work at the level of cells. But our kind of research has identified a lot of factors that promote a longer health span. So a couple of examples of the strongest predictors are a conscientious personality style. People who are careful and planful and organized tend to stay healthy longer and live longer. So high intelligence, people who are very verbal, who talk a lot, who learn quickly, who solve problems fast and efficiently tend to stay healthy longer and live longer. And then there's social connection and attachment to other people. So people who are very warm and have a close social network tend to live longer and stay healthy longer. So those are the kinds of things that psychologists can look at that tend to prolong health span. We also ask questions about who it is that ages fastest and dies the youngest. And we know that it's people from low socioeconomic status backgrounds with very low incomes tend to die youngest. People who are members of disadvantaged minority ethnic groups tend to die younger than white people. People who engage in poor health behaviors, such as smoking cigarettes or physical inactivity, tend to die young. People who experience adverse psychological states, such as mental illness, and people who experience traumatic life events. For example, people who have been maltreated or abused as a child tend to get sick younger and die sooner. So in fact, the very strongest known reducers of the human health span are poor health behaviors, adverse traumatic childhood experiences, and a history of severe stress. And these are just the kinds of things that Avshalom and I have studied in children for most of our careers. So you might notice many of these factors that affect how long we stay healthy are factors that come online fairly early in life. And there are, around the world, many longitudinal studies. These are studies that begin with young children and then follow them for maybe 5, 6, 7, 8 decades, testing their mental health and physical health all along the way. And we have one of these studies. Actually, we have 2 of these studies, one in New Zealand and one in the UK. And in these, people who performed poorly on tests and measures that were given in early childhood by our teams now tend to perform poorly on the kinds of tests that geriatric medicine doctors use to test for a risk of early death. So we've been following, for example, these 1,000 people who were born in 1972 up until today. The last time we saw them was last year when they were 45 years old. In the course of this project, we've been able to find a lot of connections from very early childhood to later aging. One of the connections we found is from the children's brain function that was tested when they were aged 3 years old to their walking speed 4 decades later. So you might think, what's walking speed? Why is that interesting? In fact, slow walking is one of the very strongest predictors of early death when you're working with older adults or in a geriatric medicine situation. You always test people's walking speed. But what we have found by following people from birth till midlife is that walking doesn't just slow down after age 60. For a lot of people, the origins of slow walking as an adult have been there all along in the brain since they were toddlers. And that's really interesting. It's interesting because it gives us the opportunity to think about prevention. What could we do with really young people that would have a payoff, a return on investment later in their lives and keep them healthy? Now, if you start studying aging by just recruiting people who are 60 years old or older, you would miss all this. We're really excited about the potential of using data on children and adolescents and young adults to try to figure out how to slow down aging.
So Terrie, in the West, it seems that advances in medical science have been successful at extending the length of our lives, but not necessarily the quality. And I'm guessing this links in with the health span that you mentioned. Is this something that you'd agree with?
Yeah, I do agree. It's obvious that people are living longer today. For example, Americans are living about 15 years longer on average than Americans did just a couple of generations ago. So this is an enormous rapid change in society. My father told me that when he was a little boy, he used to think that a person who was 60 years old was incredibly ancient, so old that you would only find those kinds of people in the Bible. But now, 60 is like the new 40. So research has shown that most of this extension of our lifespan is down to medical technology, because this is technology that is now able to keep people alive after they get diseases. It is true that the current generation tends to choose healthy lifestyles. People get more exercise and they worry about what they eat. But it's also true that we're not that successful as we wish we were, because we're the most obese generation ever. So I have to say that I wish it was that we were doing the right thing and extending our lifespan, but it's probably not something we've achieved just with clean living. What geroscientists are hoping for is something that they call compression. This is just like what it sounds. Compression means that these extra years of our lives where we live on but are disabled and rely on technology and medications to stay alive, that those years get compressed into fewer and fewer and fewer. So instead of, say, getting sick when you're 60 and living disabled until you're 90, you might not get sick until you're 85, and you'd have a compression of those years of disease and disability. So that's what geroscience is striving for.
Do you think we'll soon be able to track biomarkers of aging throughout our lives from birth to old age and making personalized medical decisions based on how those markers might change over time?
I find the potential of this really exciting, so I'm glad you asked, Sean. So what Avshalom and I have been doing is we've been tracking a couple of dozen biomarkers in 1,000 people who were born in 1972. We tested all these people when they were 26 years old, and they were at the peak of their health at that time. So we got a really great baseline on them. And then we tested them again when they were 32 years old, and then again when they were 38 years old. And then last year, we tested these same biomarkers when they were 45 years old. Now, we chose these biomarkers because we wanted to test the function and health of as many different organ systems in the body as possible. So the biomarkers test kidney health, lung health, heart health, even dental health. So what we found in this project is that for some people, their biomarker panel starts to slide downwards towards old age, unfortunately. And by now, at age 45, they're as many as 2 years to 10 years older biologically than what their chronological age is. So when this happens to people, we also then see their fitness slip, their mental function slips. When we give them tests of memory, they can remember fewer and fewer new things. And this year we scanned their brains on an MRI, and we found that their brains actually look like the brains of older people. So the amazing thing is that these people are only 45 years old, and there is plenty of time for them to turn their lifestyles around and start working toward better health. I think all they need is to be aware that there's a need to do this. So it's possible that one day people will be able to know their percentile on the pace of aging. That's really exciting, because if you could tell that you were starting to age a little too fast, you could, pick it up on your exercise, start being a little more careful and planful, but you could sort of titrate your own lifestyle according to the speed of your aging. And it would just require being able to test a biomarker panel like this. Right now, it's not available in clinical practice, but it might be one day.
I'd be intrigued to know where I am on the panel, but maybe a little scared too.
What would be exciting is to find out if you're actually younger than your chronological age. And there are people in our research who are holding they're keeping their biological age the same as it was in their 30s, although they're up in their 40s chronologically. So we're really excited to study what it is that they're doing. They're doing the right thing.
I wanted to see, maybe I can bring Avshalom into the conversation briefly on this, and just to ask about these biomarkers. And I'm particularly interested in the link between the biological functions biomarkers and the mental functions biomarkers, and if you see any correlation.
One of the things that we are seeing is that, in fact, the history of mental disorder does appear to hasten biological aging. Early onset people with persistent mental health problems are aging a lot faster. The interesting question, of course, is why is that? Is there perhaps a genetic vulnerability that jointly governs the likelihood that you will develop both a mental illness and a physical illness? That's an interesting possibility. Another possibility is that the experience of mental illness itself brings about so many lifestyle changes that those in turn hasten the course of biological aging. And if that's the case, that would suggest a whole different range of interventions that we may choose to engage in. So right now, what we are learning is that there is, in fact, a connection between the two, between mental disorder and a faster pace of aging. The catch is going to be to try to figure out what it is that's linking them so that we can effectively intervene. And as Terrie said, ultimately also help to increase health span.
Mm-hmm. Terrie, how do individual genes or individual genetics interact with the environment to determine the rate at which we age, particularly when we're young? For instance, many believe that diet or exercise is critical, but some people who have bad diets and don't exercise still live into their 80s.
Sean, you're talking about the field of interaction between genetic risk and environmental risk, and we have done quite a bit of work in this area. In regard to aging, we do. As you say, we all know somebody who smoked cigarettes every day for their whole lives and lived to be 90. That seems unfair. Or you read in the newspaper about these kind of saucy octogenarian ladies who cackle that the key to long life has been drinking a whiskey every day. So unfortunately, we have a lot of these case studies, but we don't have a lot of good genetics information yet to use for this research. It's the science on the genetics of aging is still in its infancy. It's vigorous, but and we know that there are some families who carry good genes for a long, healthy life. But the trick is how to identify what the actual genes are so that they can actually be studied. So we're still waiting for a good, solid list of genes that control aging. In the meantime, what we've tried to do is study features of people's lives that we know are influenced by their genes. And we've looked at things that run strongly in families. Just to expand a little bit on what Avshalom said a moment ago, we know that mental illnesses peak when people are in their teens and their 20s. And this is true around the world. I'm talking about schizophrenia, bipolar disorder, eating disorders, attention deficit hyperactivity disorder, but also the more common ones like depression, anxiety disorders like panic attacks, and even addictions too. So it's already well known that these mental disorders are the result of both genetic and environmental causes that are coming together in the life of one person. So typically what happens is you have an inherited genetic vulnerability, and that comes together with an intense psychosocial stress, and the result is a mental disorder. So what's this got to do with aging? Well, recently the connection has been made between mental health problems in early life that young people have and physical diseases in later life, those that I talked about that reduce the health span of a person who's over 60, over 70, over 80. We've been studying this connection using the entire population of New Zealand, so millions of people, and we've had the privilege of being given access to anonymous medical records for the population, and that's allowed us to trace medical records all the way across people's lives. And what we found, we had the hunch that people who had mental illnesses when they were young might be the same people who had physical diseases when they were older, and we found that that's definitely true. And we found that they are also dying younger compared to the rest of the population, several years younger, in fact. So this is a new area for us, but we're hard at work on this because we think it's a great prevention target to accelerate this geroscience agenda of how to slow aging to give people more healthy years. We have a hunch that it might work out that finding and treating teenagers with mental health problems would end up having the knock-on effect 4 or 5 decades later of increasing the number of years people can live without physical diseases, so increasing their health spans. And that's really an exciting prevention story. We don't have experimental evidence that it's true yet, but so far, just looking at medical records, it looks like it could work.
And it's exciting because it suggests that mental health work with young people actually provides a really great opportunity to prevent the rising burden of age-related diseases later in life, in middle age and in old age.
I think this is a good time to turn to some of the work that you're both doing on mental health. So Avshalom, why don't I come to you? A few years ago, you published a paper indicating that most people experience mental illness at some point in their life. Could you talk about these results and about their implications?
Sure. It might actually help our listeners to learn a little bit about the data that's gone into the work and how we came to this observation. So one of the research projects we work on that Terrie mentioned is the Dunedin Longitudinal study. This is a study of all the children who were born in the city of Dunedin on New Zealand's South Island. And the 1,037 children who were born in that city in 1972 and 73 have been followed up from birth now up to age 45. And over 93% of them continue to participate in the research project. Dunedin's study also occupies a rather unique place in the annals of psychiatry. Back in 1983, when the participants were 11 years old, it was the first cohort study to measure the prevalence of psychiatric disorders in children using standardized diagnostic interviews as a source of information. And since then, we've continued to interview the study members about their mental disorders, about their disturbances in thought and behavior and emotion that really interfere with or limit their family, educational, and work activities. And psychiatric interviews have now been conducted when the participants were 11 and 13 and 15 and 18 and 21 and 26 and 32 and 38 and most recently 45 years old. And each time we interview them about their mental health during the past 12 months. Now, over the years, what we've done is we've assessed what are called externalizing disorders. These are disruptive behavior disorders like attention deficit, hyperactivity disorder, conduct disorder, as well as substance dependence. We've assessed what are called internalizing disorders, things like depression, anxiety, PTSD, and eating disorders, as well as thought disorders, such as mania and schizophrenia and obsessive compulsive disorders. And this time series has yielded what is really arguably the most detailed portrait that's ever been assembled of mental health across the first half of the life course. And using these data, we've gained 3 insights about mental health and illness over the first half of the lifespan. And the first is the one you alluded to, that by midlife, over 80% of this cohort met criteria for at least one psychiatric disorder in their life. People hear that and they go, really? Are New Zealanders crazy? Are you overdiagnosing? And in fact, these lifetime rates are not that unusual. We know, for example, from studies of national registries in Scandinavian countries that the lifetime prevalence of mental disorder treatment is 30%. Okay, and treatment. But of course, many people with disorder are not treated, so we can think that this is probably a lower bound, right? Then what we have is evidence from many cross-sectional surveys. A very well-known one, excellent one, is called the U.S. National Comorbidity Survey in the United States. And the estimates here suggest that the lifetime prevalence is around 50%. It turns out that the Dunedin study, and there are a handful of other comparable birth cohort studies, all suggest that the majority of people will experience a mental disorder at some point in their life.
Can I interrupt you? It's useful to say what countries those studies are from, because sometimes people say, like you said, are New Zealanders all crazy? Some of these longitudinal studies they're in Switzerland, they're in New York, they're in
North Carolina,
where we are. So it does seem to be that it's a robust fact, regardless of where people live. Sorry for interrupting.
This is what happens when you interview a husband and wife team. I think one way we could think about this is that, some mental disorders resemble a fractured leg or the flu. They're disabling, but they're short-lived. Other mental disorders become chronic or recurrent, like diabetes, like chronic obstructive pulmonary disease. But whether they're short-lived or whether they're chronic, people who meet diagnostic criteria experience impaired functioning, and many of them absorb healthcare resources. So the message that I take away from this finding is that we need more public health education about the ubiquity of disorder, with the goal ultimately of also reducing stigma and promoting earlier and increased treatment uptake, and ultimately facilitating prevention. So rather than view mental disorders as something rare, I think members of the general public should in fact expect at least one bout of mental disorder in their life. There are two other insights that we've gained that go hand in hand with this observation about how common mental disorders are. The second one is that the majority of adult patients with a psychiatric disorder, and Terrie alluded to this, have their first diagnosable disorder before age 15. The thing about early onset disorders that onset in the first 2 decades of life, is that they tend to last longer and they tend to be more pervasive, and they often tend to morph into what are increasingly more complex and comorbid conditions. And all this suggests is that most of the burden of mental disorder actually could be prevented by effective screening and treatment of young people. A third insight that we've gained is that few people actually retain just one disorder over their life. Rather, what we see is that the more typical pattern is for people to shift between different disorders. Children with ADHD are likely to develop thought disorders. People who develop depression are likely to go on to develop substance dependence. People who develop substance dependence are likely to go on to develop anxiety. And this insight is important because it helps us actually account for one of the more interesting findings that's emerged in genetics and in neuroscience, which is that many different psychiatric disorders actually share the same risk factors. And what our data suggests is that, in fact, that shouldn't be too surprising that different conditions have the same causes, because, in fact, it turns out that oftentimes the same people have different conditions when we follow them up over time. And this also implies that what we need to do is really think about how to evaluate and to roll out different treatments. Given that most mental disorders appear to morph into different disorders, therapy doesn't just need to address the presenting disorder, but what we need to also do is help people, and especially young people, build fundamental skills for maintaining their general mental health across time. And I think that's a really important message to emerge from what we have seen looking at the natural histories of mental disorders.
Are there any particular markers or behaviors in children that would predict mental health in adults?
That's interesting. Given that most of us will experience a mental health problem at some point in our lives, we can't do a very good job predicting it because, other than to say, look, we're all vulnerable. So rather than try to predict whether we'll experience a mental disorder or not, the goal should be to see if we can predict 3 important sort of features of poor mental health that we know signify especially poor prognosis. And the 3 features are the early onset of a disorder, the persistence of more or more frequent recurrence of a disorder, and the diversity of mental health problems. That is, the multiple different comorbid conditions that we may have. So are there, in fact, behaviors in children that can predict mental health issues later in life? In fact, we can actually do best by assessing behaviors that actually occurred even before children were born. And in particular, a family history of psychiatric disorders is one of the best predictors that we have of developing mental health problems. And the reason is that a family history of mental illness actually gives you information both about genetic risk and about environmental risk, right? Mental health problems are a product of our genetics, of our environments, and of the interplay between the two. So, for example, mentally ill parents are often unable to provide a nurturing and a protective environment, and these 2 factors may exacerbate the risk of a child developing mental health problems. By collecting family history in one fell swoop, right, in a single measure, what you are able to do is gain insight into the risks with which you were born and the risks to which you might be exposed growing up. Family health histories, are often gathered in relation to physical diseases, but they're less often collected in relation to mental health issues. And one of the reasons for this is that mental disorders are often hidden, right? Family members don't often reveal them to other family members. And even when they are known to family members, they're often just not discussed. And that's one of the most pernicious costs, really, of stigmatizing mental illness, that we don't allow our relatives to learn and to know about their risk. Look, the bottom line really is that the best way to protect your health is to get to know your own family history and ultimately to act on that family history in order to promote and to preserve your own health.
I don't want to dwell on the negative, but your evidence seems to imply that certain children are doomed from the start. Is that true?
Psychology is a really funny business. It's perhaps the only kind of business, if you will, where prediction is feared, right? When an engineer builds a bridge, right, you want to make sure that it's going to be stable when you cross it, right? Being able to predict is really highly valued. But somehow when it turns to forecasting the future of a child, we tremble at the prospect of doing that. And I think I'd like to turn it around and suggest that prediction is ultimately the most important tool that we have for improving life chances for everyone. So we shouldn't fear prediction. We should, in fact, seek to do a better job with it. If I can for a minute to just give you an example from our research where we've struggled a bit with this issue. And this has been work that we've done to see whether or not we could actually predict the small segment of a society who would prove to be the most costly. And to do this, one of the things that we've done is we've integrated multiple nationwide databases about crime, about social welfare, as well as electronic medical records, about hospitalizations, about prescription drugs, with our Dunedin longitudinal study data. And what we wanted to see is that if we could predict the minority, that is the small number of individuals who accounted for the majority of economic costs in the population. It's actually an old idea here that we're looking at. It goes back about 100 years to a man named Vilfredo Pareto. Pareto was an Italian sociologist, economist, and philosopher, and he identified an interesting principle, namely that 20% of the actors account for about 80% of results. He made this initial observation about wealth, where he observed that 20% of families in Italy owned about 80% of the land back in the 1800s. But the idea is still in use today. In software programming, we know that 20% of code has 80% of errors. My favorite, Terrie's favorite, 20% of women buy 80% of shoes.
Yes, I read this in Vogue magazine.
A great scientific resource.
Yes.
Absolutely. We only cite the best. We actually showed as 20% of the population accounted for a disproportionate share of several different health and social problems in society, of criminal convictions, of hospitalizations, of social welfare benefits. And we also found that these individuals shared key risk factors early in life. And specifically, when we reach back to age 3 years, when each child in the Dunedin study was assessed for about 45 minutes in a pediatric examination, which included things like whether the child understood the words, the sentences, and meaning of what others say, that included the test of motor development, that evaluated the child's self-control, whether they got frustrated easily, whether they were restless and lacked persistence and were impulsive. What we found when we went back to these early records was impressive prediction. Given 2 3-year-old children, one who grew up to belong to multiple high-cost groups and one who did not, this 45-minute assessment was able to classify the children accurately 80% of the time on outcomes 35 years later. So is this disturbing? Well, our research here was guided by the need to answer a straightforward policy question, which is investment in early childhood intervention justified by strong connections from childhood to adulthood? And we did find a strong connection. We found that multiple health and social problems are concentrated in a segment of the population that is small and that is predictable. The problem is that we also know all too well that these kinds of population segments, often are really highly stigmatized. So the data does have a side that's troubling, no doubt. Predicting behavior poorly, as we've done in the past, is tolerable to many of us. Predicting it well often runs the risk of opening up a Pandora's box. I'm concerned, really, that this research should not be misused to blame victims, and that's the concern that we have. But far from it, my hope is that we actually use this research and our ability to predict well to make the case for compassion, for helping children to get a better start in life. Basically, what the findings suggest is that, the well-being, the prosperity of a nation is really closely tied to the well-being and the health of a child. And health and education policy needs to promote the healthy development of children, not only because it's the right thing to do for children, not only because of compassionate reasons, but because doing so is actually going to improve the prosperity of the entire population. So I think it's not that our ability to predict is in and of itself dangerous. It's rather how we use that information that is most important, and to use it in a way that is both compassionate and also seeks to improve the lives of others.
I love what Avshalom has said. I think that a lot of people have said, well, it's amazing that you can use the data that were collected in the 1970s for these 1,000 people that we've studied to make predictions about or to identify connections with their adult mental health and physical health. What I think is really wonderful about that super early prediction is that it illustrates that these children didn't have a fair start right out of the starting block. Their lives are not turning out to be unhealthy because they've made poor choices, or they've been lazy, or they've, opted for the easy path in life, or, they're undeserving members of society. None of that. The risk has been there for a long, long time, and before they actually had any control of how their lives have turned out. That's not to say people can't make choices. They certainly can. But to me, when I realized the connections began in the very first years of life, that just turned on the compassion button for me.
So, Avshalom, what are some of the interventions that could reduce the chance of mental illness in later life and improve overall child well-being?
To answer this question, I actually want to go back to the first question that you asked of me, which was about the ubiquity of mental health problems. What I see in these data is a great unmet need for mental health care. We know that access to mental health care is much worse than access to other types of medical services. And attitudes about mental health services represent yet another barrier to care. And I think what this means is that we really need to rethink the provision of mental health care. And we can do so by thinking in three ways. First, at the healthcare system level, we need to be better prepared and more transparent in how we handle mental health cases. Services are often provided in a very fragmented way. They're often insufficiently coordinated. And the current structure of health insurance, for example, in the United States, makes it more difficult for people to receive mental health treatment than for other mental health conditions. So that's at the healthcare system level. At the training level, we need to do a better job teaching healthcare providers about mental health. Currently, we don't do a very good job, I think, training our general practitioners to recognize mental disorder. And primary care doctors often must learn how to refer patients for proper treatment, and we need to be doing a better job training for that. And finally, at the treatment level, we have to develop new treatment tools other than one-to-one treatment between therapist and patient. That continues to be the model of healthcare delivery, and service delivery at this level is simply outmoded. It's expensive, it's elitist, and it's not sustainable. So I think one of the things that I've really taken away from our research about mental disorder is to really go back and to think, given how ubiquitous mental health problems are, what do we need to be doing better at the healthcare system level, at the training level, and also at the treatment level of addressing what is a widespread phenomenon.
So I have just one final question that I'd like to address to both of you. Tell you what, Avshalom, we'll start with you. How will the work you're doing have a measurable impact in the lives of children? And importantly, how can this be assessed?
I think that if we made mental health services acceptable, available, and more sought after, if we made parents, teachers, GP, police officers all more aware of many of the mental health issues that children are already struggling with early on in life, my hope is that this will have the kinds of knock-on effects that we'd like to see in reducing trouble that children have in negotiating the transition to adulthood and ultimately in increasing the health span of the population.
I think what our research has been doing is to really point out with hard, cold numbers how important it is for every child to have a good childhood. We've been able to do this by showing that the effects of a disadvantaged childhood reverberate right throughout the entire life course. And therefore, if you could give every child a good childhood, a healthy childhood, that would have a return on investment right into late life. It would, make the lives of elderly people more comfortable, have better quality of life, less disease, less illness. That's exciting to think that it's really important to give each child a good childhood. And the other thing I think that we have found is that, when I first started my career, I thought, okay, what accounts for how people's lives turn out? It's their IQ and it's the social class they're born into. It's how smart they are and how much money they have. But in fact, we always use those as comparison factors in our research. And we have found that they're not the end all and be all, that, IQ, intelligence and money are not the main explainers of how life turns out. And in fact, we've identified all manner of other points of intervention and prevention and things that can be done, things that we can be very optimistic about. So I think that we've done a lot to point out that giving every child a good childhood is absolutely necessary. It's vitally important. And to show that it can be done. We don't have to be pessimistic that nothing can be done to help children.
Terrie, Avshalom, I want to thank you so much for your time and wish you all the best with your work. It's really been fantastic talking to you both, and I hope to see plenty more of your research published in Science.
Me too. My pleasure.
Great to chat with you. Thank you so much.
And thank you to our podcast audience for joining us. If you'd like to send us your feedback or suggestions, please send an email to custompodcast@aaas.org. For more podcasts in this series, please visit the Blog on Learning and Development website by going to bold.expert. And thank you once again to Dr. Terrie Moffitt and Dr. Avshalom Caspi, and to the Jacobs Foundation for making this series possible. I'm Sean Sanders. Thank you for listening.